Welcome to AETCM, the Emergency Medicine Channel. Myself, Dr. AVIN John. I'm a PG resident from the Department of Emergency Medicine. So as part of our EM Rapid program, I'm presenting the topic anti-arrhythmic agents. So we all know arrhythmias are one of the most important causes of the sudden cardiac death, and also these agents, these anti-arrhythmic agents, they act mainly by two mechanisms. One by modifying the autonomic function or by modifying the ion channels, the myocardial ion channels, and this causes changes in the conduction velocity as well as the refractory period, and it suppresses the abnormal automaticities, and this causes the pharmacological conversion or rate control of the common arrhythmias. So long-term use is not proven to reduce any mortality, and also these drugs have narrow therapeutic index, and these can cause pro-arrhythmic action. So it is mainly used as a short-term measure to control these arrhythmias. So we have most common causes for these arrhythmias, such as the cardiac and the non-cardiac causes. So in cardiac causes we have MI, heart failure, valvular heart diseases, cardiomyopathy, hypertension, pericarditis, endocarditis, or other non-cardiac causes like the electrolyte imbalances which cause these arrhythmias, or the pH imbalance, hypoxia, pulmonary embolism, trauma, sepsis, hypothyroidism, CVA, and other drug influences as well. And coming to the classification of arrhythmia, it is based on the anatomic site of abnormality, which is it can be at the atria, AV node, or ventricles. So the common arrhythmias depending on the site, we have the atrial arrhythmias, which includes atrial flutter, atrial fibrillation, and supraventricular tachycardia. We have AV nodal re-entry tachycardia as well as acute supraventricular tachycardias as well. And ventricular tachycardias, we have mainly two, which is the VTs, which is the ventricular tachycardia, and the ventricular fibrillation. And if the rhythm or the electrical activity comes from any other site other than the SA node, then the arrhythmias arise, and that is in a way to say that the automaticity arises from a different site other than the SA node. That is one of the mechanisms for the cause of these arrhythmias. And also another mechanism which you have heard about is the re-entry mechanism. So in this, if there is a unidirectional block caused by a myocardial injury or a prolonged refractory period, it results in another abnormal conduction pathway. So this causes the re-entry circuits, and which propagates the arrhythmia. And these agents prevent the re-entry. The anti-arrhythmic agents, they prevent the re-entry or the automaticity by slowing the conduction, or by decreasing the frequency of discharge, and by increasing the refractory period, as we mentioned earlier. Coming to the electrophysiology, the cardiac electrophysiology, we know heart contains specialized cells, such as in the SA node we have the specialized cells in which has the property of automaticity, which I had explained earlier. This automaticity is actually the capability to produce action potential without any external stimulus. So that automaticity is what drives the whole electrical activity in the heart. So first of all, if you look, it will start the excitation signal, or the action potential will start from the sinoatrial node. It passes along the atria, which causes it to contract, and there will be a AV nodal delay, as we all know, and after that it passes on to the bundle of His, and it gets divided into the fascicular branches, as we know, and finally terminates with the Purkinje fibers, and these causes the ventricular contraction. This whole will cause the ventricular contraction. And coming to the action potential, how is it generated, and the graph concerning the action potential. So first of all, if you look, the y-axis as membrane potential and x-axis as time. So once we all know that the resting membrane potential of a cardiac muscle is around minus 90 millivolts. So once the basic what initiates the action potential is basically the sodium channels. So once the rapid sodium influx occurs through the open fast sodium channels, so the sodium channels open up and the sodium influx starts to occur. So once the sodium influx starts to occur, what happens is the negative charges within the membrane, within the cell, that starts to become less and less negative, that is more and more positive. So this minus 90 millivolts, it starts to increase once sodium starts to get inside the cell, and once it reaches a peak, what happens is there will be the beginning of potassium efflux. That is, we all know that potassium is more inside the cell and sodium is more outside the cell, and the relative concentrations of each of these ions is what is responsible for that membrane potential. So what happens is the sodium influx will cause more and more positivity of the membrane potential, as well as once it reaches a peak, what happens is the potassium channels starts to open up. The potassium channels open up and the efflux starts to occur. So the positive ions are getting out of the cell. So once it gets out of the cell, what happens is the membrane potential again returns back to 0, because the positive charges are getting out and the negativity within the cell increases, and the membrane potential comes back to 0. And after that, the calcium channels open up, and the potassium as well as the calcium channels, they balance and form the second phase, which is the plateau phase. The plateau phase, after some time, this calcium channels close. So once the calcium channels close, again the potassium efflux is only happening. So more and more positive ions are getting out of the cell, and this causes again increased negativity at the membrane level, and it returns the membrane potential to minus 90 millivolts. And at the phase 4, we have only the potassium channels open and the sodium and calcium channels are completely closed, and this potassium channels actually keep the membrane stable at minus 90, which is the phase 4. So we have 4 phases in the action potential. And coming next, we have the classification, which is the Vaughan-Williams classification of antiarrhythmic medications. According to that, we have 4 classes: 1A, 1B, 1C, 2, 3, and 4. So class 1 is basically based on sodium channel blocking action. Class 2 are the beta blockers. Class 3 basically act as a potassium channel blocker, and class 4 as a calcium channel blocker. So these examples also we have. Most common: 1A, we have the procainamide; 1B, lidocaine; 1C, flecainide and propafenone. Class 2 includes esmolol, labetalol, metoprolol, propranolol. Class 3 has amiodarone, dronidarone, dofetilide, ibutilide, sotalol, vernaculant. Class 4 has diltiazem, verapamil, nicardipine. So coming to each of these in proper, we have class 1 antiarrhythmic drugs. These, as we discussed now, it actually blocks the fast sodium channels, and it's further categorized based on the strength of the blockade. So it can be categorized into moderate, weak and strong blockade based on 1A, 1B and 1C. So in 1A, moderate blockade, it slows the rapid upstroke, the initial phase which we had seen in the action potential graph. During the phase 0, the rapid upstroke is slowed down, and it also decreases the slope of the phase 4. By preventing the sodium influx, it also inhibits the potassium calcium channels as well, and this lowers the conduction velocity and increases the refractory barrier. So most of the antiarrhythmic agents have a similar mechanism of action. Then coming to 1B, weak blockade is mainly shortens the phase 3. The phase 3 is what is shortened, and it decreases the duration of action potential and blocks sodium channel. Strong blockade is by 1C, which is it suppresses the phase 0, as we discussed earlier in the 1A as well. Phase 0 of upstroke is suppressed in the His-Purkinje system and ventricular myocardium mainly, and it increases the threshold potential, and this is what reduces the automaticity. And flecainide also blocks the potassium channels, whereas propafenone has a weak beta blocking property. And they increase the excitability threshold, which requires more and more sodium channels to open up in order to overcome the potassium current and generate an action potential. And this is what it increases the refractory period, decreases the automaticity and conduction, and is useful to terminate these arrhythmias. And coming to class 1A, procainamide is very less commonly used. To be honest, it is less commonly used in the ER, and we use it mainly for ventricular arrhythmias and supraventricular arrhythmias, and also rhythm control in AF of onset less than 48 hours. And these are the pharmacokinetics, especially the hepatic and renal metabolism and excretion via urine and feces. The onset of action is immediate onset of action, and the duration of action is around 3 to 6 hours. The dosage, we usually have a loading dose of around 20 to 50 mg per minute till 70 mg per kg we can give, and maintenance of infusion of 1 to 4 mg per minute. We should stop the infusion if there is any hypotension or bradycardia. And these are also the common side effects which we see with these antiarrhythmic agents, which is the hypotension, bradycardia. and also the pro-arrhythmic effects of some agents as well. Adverse effects also, as we discussed, hypotension, cardiac conduction abnormalities, and rash. The other serious side effects, we have the pro-arrhythmic effects as well, prolongation of the QT interval, torsades de pointes, ventricular fibrillation, and all that. It can also cause hepatotoxicity and congestive heart failure, which is also a common adverse effect in most of these agents. The lidocaine agent is mainly used in ventricular arrhythmias, pulseless VT or VF, and as an alternative to amiodarone, as we have seen in the AHA guidelines. It's either amiodarone or lidocaine, which are used for patients refractory to CPR and defibrillation, and the pulseless VT or VF continues to go on. And we should also continue the lidocaine maintenance. Once we started in the during the resuscitation, we'll have to continue it post-ROSC as well. And these are the metabolism. It's mainly by hepatic metabolism, and the excretion is via urine. And the onset of action is around 45 to 90 seconds and lasts for around 10 to 20 minutes. Okay, and the dosage of in sudden cardiac arrest, we all know it's loading of 1 to 1.5 mg per kg, and we can repeat the doses half of it, which is 0.5 to 0.75 mg per kg every 5 to 10 minutes. Maximum we can give 3 mg per kg within 1 hour, and the endotracheal dose is around 2 to 3.75 mg per kg in 5 to 10 ml sterile water. We'll have to give double the dose of the IV dosing in endotracheal dosing. And maintenance, we can give it as 1 to 4 mg per minute. And adverse effects, it has actually a wide therapeutic index, whereas certain antiarrhythmic agents have only narrow therapeutic index, as I mentioned earlier. And since this has wide therapeutic index, the side effects are very minimal. And the most common side effects of early toxicity is what we see as CNS effects, which is the nystagmus. So nystagmus is an early sign of toxicity, and we have other CNS signs as well, which is include numbness, speech impairment, somnolence, seizures, dizziness, and all. And further, we have the class 1C propafenone and flecainide, which is also rarely used in our ER. And indications include SVT, AF, which is less than 7 days. Paroxysmal SVT, VT is rarely used for these indications as well. Pharmacokinetics is hepatic metabolism, is excreted in urine and feces. And dosage wise, propafenone dosage is one-time oral dose. Both are one-time oral dose. Propafenone is 450 mg one-time oral dose for less than 70 kg, and 600 mg for greater than or equal to 70 kg. Flecainide is also 200 milligrams one dose, one single dose, and less than 70 kg is 200 milligrams, and 300 for greater or equal to 70 kg. Adverse effects, it has also a wide therapeutic index, and the similar side effects of antiarrhythmic agents are also seen here. Also, there can be bronchospasm and other arrhythmias as well. And flecainide also has a similar adverse effects with the exception of bradycardia and bronchospasm, which occurs only with propafenone. And both these agents should be avoided in patients with congestive heart failure, significant structural heart diseases, hypokalemia, or AV blocks as well. And coming to class 2 antiarrhythmics, which is beta blockers, they act by blocking the catecholamine effects on beta receptors. And beta 1 receptors are mainly found in heart muscle, whereas beta 2 are found in the bronchial and vascular smooth muscles. So we have two types based on that: non-selective beta blockers as well as selective cardioselective beta blockers. So non-selective targets, as we all the names itself says, it targets all the receptors and decreases the heart rate contractility, prolongs AV conduction, and also it has the beta 2 action as well, beta 2, beta 3 actions as well, and it affects the smooth muscle contractions as well as increases the risk of bronchospasm. So you have to be careful in giving to patients with asthma as well. And in contrast, the cardioselective agents, it has selectivity for the beta 1 receptors, and it decreases only the heart rate and blood pressure. So it's better for patients with asthma, COPD, or type 1 DL. And the cardioselectivity is lost at higher doses, but and also they mainly diminish the phase 4 depolarization part is mainly diminished. And indications, as we know, it usually most commonly used for hypertensive patients, and also we can use it for SVT, VT, and ventricular arrhythmias as well. And also in recurrent AF as well, we can use it for rate control of recurrent AF. And other uses are also used in symptom control and thyrotoxicosis. And coming to the propranolol drug, which is a non-selective beta blocking agent, it reduces the heart rate, myocardial contractility, BP, and the myocardial oxygen demand as well. The pharmacokinetics, it's mainly onset of action orally, it's within 1 to 2 hours, and in IV it's a rapid action with less than or equal to 1 minute, and orally it takes around 6 to 12 hours, and in IV wise it takes around 4 to 6 hours. it lasts for around 4 to 6 hours. As well as metabolism is mainly hepatic metabolism with extensive first pass elimination, and the indications, as we said earlier, it's used for hypertension, supraventricular arrhythmias, ventricular tachycardias, and all. The adverse effects of almost all beta blockers are the same. Bradycardia, heart blocks, it can cause hypotension, it can cause and heart failure worsening, it can cause and bronchospasm if it is a non-cardioselective, non-selective beta blocking agent as well. And dosage of that in AF we usually use in our year. So AF we usually use 1 mg or 1 minute, and we have to repeat the dose as needed every 2 minutes up to a maximum of 3 doses we can give of 1 mg. And maintenance dose is oral dosing, which is 10 mg 3 to 4 times daily, and we can give up to maximum 40 mg 3 to 4 times daily. And also for VT, acute VT, we can give around 1 to 3 mg similar dosing, 1 to 3 mg every 5 minutes, up to total of maximum 5 mg we can give in VT. And also we have to give this with an oral anti-arrhythmic agent, because this is mainly rate control which is being done by these agents. So the anti-arrhythmic agent has also to be added to these agents. And oral dosing is 40 mg, oral dosing every 6 hours with an IV anti-arrhythmic. And for prevention also, we have prevention of VT and VPCs and all, we have similar dosing 10 to 40 mg every 6 hours. Coming to esmolol drug, it's also actually a short-acting selective beta-1 antagonist. So it has mainly these negative inotropic chronotropic effects. It prevents excessive adrenergic stimulation of the myocardium, which increases the sinus cycle length, prolongation of the SA node recovery time, and decreasing the conduction through the AV node as well. And coming to the pharmacokinetics, it has onset of action around 2 to 10 minutes, and the duration lasts for around 10 to 30 minutes. It's mainly metabolized in blood by the RBC esterases, and it's used for similar indications as well, and adverse effects are also similar. And coming to dosage wise, we have 500 microgram per kg over 1 minute IV dosing, and we can administer repeat bolus doses of 500 milligrams per kg, and prior to increase each increase in continuous infusion rate in order to achieve a more rapid response. So the continuous infusion dosing is 50 microgram per kg per minute, and we can increase in increments of 50 microgram per kg per minute, and maximum we can give around 300 microgram per kg per minute. And VT also we have a similar dosing of 500 milligram per kg bolus followed by 50 microgram per kg per minute. And metoprolol is a selective beta-1 antagonist, and it also reduces the cardiac output, reduces the sympathetic outflow, and suppresses also the renin activity as well. The onset of action orally it is less than or equal to 1 hour, whereas IV it is 20 minutes. And duration of action, the oral tablets it is variable, and IV it takes around 5 to 8 hours. And metabolism wise, it's a hepatic metabolism, similar extensive first pass elimination as esmolol, and half-life is around 3 to 4 hours. It's used for hypertension, acute MI or angina, and it has similar side effects as well: bradycardia, heart block, hypotension, and bronchospasm. We should avoid these drugs in patients with decompensated heart failure. That is what is you have to be very clear about. The decompensated heart failure, if we start these agents, it will worsen the existing heart failure. So in AF or a flutter, which is used for rate control, or SVT as second line, we can give around 2.5 to 5 mg over 2 minutes, and we can repeat doses every 5 minutes as needed, maximum dose of 15 mg. And maintenance or for AF prevention after cardiac surgery, we give it as oral dosing 25 mg BD and titrate to 200 mg per day in 2 to 4 divided doses. Ventricular arrhythmias, we have to give similar dosing. We can give 5 mg every 5 minutes up to 3 doses. And prevention of ventricular arrhythmias or non-sustained VT, we can give oral dosing of 12 to 25 mg BD, similar dosing as before as well, and 200 mg per day in 2 to 3 divided doses. And labetalol is mainly used for only in hypertensive emergency cases, and it's actually a combined selective alpha-1 blocking and greater non-selective beta antagonist action with direct vasodilatory action. And pharmacokinetics wise also, its oral onset of action is 20 minutes to 2 hours, whereas IV it is rapid with less than or equal to 5 minutes. Duration of action orally 8 to 12 hours it will take, whereas in IV it lasts for around 16 to 18 hours. And metabolism also similar metabolism as before, and its adverse effects are orthostatic hypotension, heart failure, hyperkalemia, bronchospasm, nausea, dizziness and all. And dosage wise, in hypertension emergencies, we give it as IV bolus of 10 to 20 mg over 1 to 2 minutes, followed by 20 to 80 mg every 10 minutes until we get the target BP, or we can start it as continuous infusion. Because starting continuous infusion directly, we have to start with a loading dose of 10 to 20 mg over 20 minutes, over 2 minutes, and after that we have to continue it with 0.5 mg to 2 mg per minute. Some may require up to 10 mg per minute as well, which is a very high dose, and it's not mainly used for any, it's not used as an anti-arrhythmic agents. Okay, and further we have carvedilol, which is actually a non-selective beta blocker and alpha-adrenergic blocker. It reduces the cardiac output, exercise-induced tachycardia, reflex orthostatic tachycardias, and also it causes vasodilatation and decreases the peripheral vascular resistance. And this also helps in reducing the BP. It's mainly used in hypertension as well, with, and also in compensated heart failure with reduced ejection fraction as an alternative in addition to the ACE or IRBs. And the onset of action is around 30 to 60 minutes, and we have duration of action from 14 to 20 hours, and hepatic metabolism, and also it can cause similar side effects of the beta blockers as well. And dosage wise, in AF, flutter or non-sustained VT or VPC is rarely used. The maintenance dose is orally 3.125 mg BD up to 25 mg BD. And coming to class 3 antiarrhythmic drugs, we have these mainly inhibit the inward potassium currents, leading to a longer refractory period. Since the myocardial tissues in refractory state, they are resistant to all these re-entry circuits as well. And also it prolongs the QT interval, which is a major side effect of these drugs, and is associated with significant risk of torsades de pointes, and is mainly used for mainly supraventricular arrhythmias and ventricular arrhythmias. So amiodarone is mainly used for the rate control or cardioversion and maintenance of sinus rhythm in supraventricular arrhythmias, whereas in ventricular arrhythmias it is for suppression and management of the life-threatening arrhythmias, ventricular arrhythmias. And dronedarone is mainly used only for supraventricular arrhythmias. It has lesser side effects than amiodarone, as it is less lipophilic, whereas amiodarone is more lipophilic. And it also is used in, and dronedarone is used in atrial fibrillation with history of paroxysmal or persistent atrial fibrillation, but currently in sinus rhythm, not in patients who is actively in AF, but who has recovered from AF and is in sinus rhythm. In these patients, we can start dronedarone. Reduces the risk of hospitalization as well. And sotalol is used for atrial fibrillation, atrial flutter, and monomorphic VTs. Doftilide is used for similar case scenarios, and ibutylide and vernicline is also used for similar case scenarios. And coming to the ion channels and receptors antagonized by these agents, amiodarone, it antagonizes almost all the channels and receptors, which is the potassium, sodium, calcium, and the beta adrenergic and alpha adrenergic blocking actions as well, and same goes for dronedarone as well. Sotalol has only a potassium channel blocking activity, and doftilide also has a potassium channel blocking activity. Ibutylide has a potassium channel blocking activity, but it activates a slow inward sodium current. Vernicline blocks both potassium and sodium channels. Coming to the actions, we have the, as we said, amiodarone. It blocks all the channels and receptors. Its effects on cardiac electrophysiology is that it prolongs the refractory period, and also it decreases the SA node function, and it slows the AV node function. So it slows the whole pathway of the cardiac electrical activity, and it also modifies the automaticity of Purkinje fibers. And what happens is it decreases the heart rate, and it can also cause sinus bradycardia as well. So it prolongs all the intervals. So since it goes slowly through the entire electrical circuits, it prolongs the PR interval, QRS interval, and the QT interval as well. And coming to the indications, as we discussed earlier, it is used for an atrial fibrillation, ventricular rate control, and you should also consider the risks of cardioversion, which includes the thromboembolic complications. So we'll have to anticoagulate the patient before doing this, or we'll have to do a screening echo to rule out any LA clot. And further, it is a first line option in patients with heart failure. It is also considered when other measures are ineffective or contraindicated. In PPW syndrome, we should actually avoid amiodarone, because if it's a pre-excited atrial fibrillation, it will, instead of slowing the ventricular rate, it will accelerate the rate because of that extra accessory pathway in PPW syndrome. And AF, it can also be used for cardioversion as well. It is not first line, but it's a reasonable option, and we usually most commonly use in ER for that same purpose. But it takes around 24 hours to cardiovert the patient, as it is slow in onset. And monomorphic VTs, it can in monomorphic VTs it is used as a first line agent for hemodynamically stable VT, and for polymorphic VT not associated with long QT only we'll use it. And in pulseless VT or VF, it is the antiarrhythmic of choice as per our ACLS algorithm. And the pharmacokinetics, it's as I said earlier, it is highly lipophilic, and it's extensively distributed to these body tissues. And so we require large oral or IV loading doses to achieve a sustained serum concentration. So the oral bioavailability is around 35 to 65%, and the distribution is very huge. It is 66 liters per kg, and plasma protein binding is more than 96%. Hepatic metabolism via CYP 450, and it is excreted via feces and urine. And in onset of action of oral dosing is around 2 days to 3 weeks it will take, whereas IV, its initial effects are rapid and it peaks within 1 week to 5 months, and the duration is variable from 2 weeks to several months it can last. And coming to the dosage, it is mainly prepared with 5% dextrose in water, as it precipitates with NS. So that part of it we have to be careful. We should start it only by mixing with 5% dextrose in water, and infusion rate should not exceed 30 mg per minute. That's the maximum we can increase it. And the dosage adjustment is required for hepatic dysfunction as well. Severe hepatic dysfunction requires dosage adjustments as well. And indications and the dosage we have in cardiac arrest, which is refractory to defibrillation, 300 milligrams rapid bolus, which we can give as undiluted dose, and we can repeat with 150 milligram boluses as required. And for VT with pulse and AF or atrial flutter, we can use the dose of 150 milligrams in 100 ml of D5 water over 10 minutes. And this is what we load the patient with, and after that we start the infusion, which is at 1 milligram per minute for 6 hours, or then followed by 0.5 milligrams per minute for the next 18 hours. So total of 24 hours of infusion is required for pharmacological cardioversion. And if any arrhythmia occurs while during the infusion, we can repeat the bolus doses, and maximum total dose is 2.2 grams. And adverse effects is it's a strong inhibitor of the hepatic enzymes, and it increases the concentration of other medications. So it has multiple adverse effects based on different systems. Cardiovascular side effects include, it slows everything down. So it causes sinus bradycardia, ventricular arrhythmias as well. It's a pro-arrhythmic agent. So it causes Torsades de pointes. It increases the risk of QTC prolongation when used with other agents, or in hyperkalemia, hypomagnesemia. It can also cause thrombophlebitis if given by peripheral line. So we'll have to put either an extra line via the EJV or by IJV, and it also can cause blocks as well, AV nodal blocks, and it can cause hypertension if we give it at a faster infusion rate. And in CNS side effects, it's mainly paresthesias and peripheral neuropathies, dizziness. GI side effects are nausea, vomiting, anorexia, constipation, and it responds to dose reduction. And hepatic wise, it requires monitoring because it increases the liver enzymes. So we have the baseline LFTs have to be monitored every 6 months, and it's actually hepatic injury is mild and reversible, but liver failure can also occur. So pulmonary side effects include the pulmonary toxicity, which is the pulmonary fibrosis. It can cause allergic alveolitis, interstitial pneumonia, eosinophilia. So the PFTs have to be seen, and the chest radiographs have to be taken annually. And thyroid also, it causes both hypothyroid most commonly and less commonly hyperthyroidism. So the TFTs also has to be monitored every 3 to 6 months. And pregnancy, it is contraindicated. Even ronidaron is contraindicated in pregnancy, and ronidaron is a non-iodinated, less lipophilic derivative of amiodarone. So because it's less lipophilic, it's less distributed in the bodily tissues, and it has fewer side effects. It has all 4 antiarrhythmic class effects with alpha-adrenergic antagonist activity, and it blocks the it mainly prolongs the refractory period. That is its main mechanism of action. And pharmacokinetics wise, the volume of distribution is around 1400 liters, plasma protein binding of greater than 98%, hepatic metabolism similar to that of amiodarone, CYP 450, and the metabolites excreted in feces and urine, half-life of around 13 to 19 hours. Indications, it is mainly used only in patients with past history of paroxysmal or persistent AF, only history of paroxysmal persistent AF, but now the patient is in sinus rhythm. So we are starting these patients to prevent AF, not to treat AF, but to prevent AF, and not used in patients, as I said, who is in permanently in AF or with symptomatic heart failure or in pregnancy. If the patient is found to be in AF, then the dronidone agent has to be discontinued. The dosage is 400 mg BD with food to increase bioavailability. The adverse effects are also, we have similar side effects. Cardiovascular, we have new onset of worsening heart failure, then the QTc prolongation. Hepatic also, it causes severe liver injury. Renal also, it increases the creatinine by around 0.1 milligram per deciliter. Respiratory wise, it causes similar side effects of pulmonary fibrosis, pneumonitis, it is ILDs, and contraindicated with patients of heart failure, decompensated heart failure, and also in permanent atrial fibrillation patients and severe hepatic impairment or previous liver or lung toxicity with amiodarone. Also in patients with bradycardia less than 50 beats per minute, QTc is prolonged or PR interval prolonged, that is the blocks or the bradycardia patients or the patients who can go into torsades de pointes. These patients will have to avoid the use of this dronidone agent. And the drug-drug interactions are also common with strong CYP450 inhibitors and QTc prolonging medications as well. And pregnancy also, it is contraindicated. And coming to sotalol, which is a non-cardioselective beta blocker, it prolongs the repolarization and refractoriness without affecting the conduction, like the class 3 antiarrhythmics. But it's a beta blocker. So since the action is similar to that of class 3, it has been grouped in this class. The pharmacokinetics, onset of action is 1 to 2 hours for oral and 5 to 10 minutes after IV administration. The elimination half-life is 12 hours and it increases with renal dysfunction as it is eliminated unchanged in the urine. Indications is usually used for refractory arrhythmias. It suppresses the SVT AF, but is not indicated for cardioversion of AF, only rate control. And dosing, it is oral doses around 80 mg BD with maximum dose of 160 mg BD. IV doses 75 mg infused over 5 hours twice daily. Pre-treatment QTc should be checked, it should be less than the 450 mark, and we have to monitor the QTc because they have more chances for going into torsades de pointes because of its pro-arrhythmic effects. It can also cause similar side effects of bradycardia hypotension. And dofetilide is also a pure class 3 antiarrhythmic, and it's rarely used. It is used for AF or flutter for conversion and maintenance of normal sinus rhythm. It is only reserved for highly symptomatic patients in whom other agents are contraindicated due to its pro-arrhythmic effect. It can cause similar side effects of VT, QTc prolongations. Drug interactions, it is contraindicated with verapamil and other drugs, hydrochlorothiazide, cimetidine and all. And because these drugs actually, this dofetilide, it increases the plasma concentration of these drugs. And coming to ibutilide, which is it prolongs mainly the refractory period. Similar action in atria and ventricle caused by the activation of slow inward sodium current is also there as part of its mechanism of action, and it blocks the potassium current, which slows the repolarization. So its onset of action is less than or equal to 90 minutes. It's metabolized in the liver and excreted in urine and feces. These are also less commonly used in ER, and its indication is mainly a rapid conversion of recent onset AF or flutter to sinus rhythm within 1 hour. And for patients with AF and an axillary pathway, it is used as a reasonable option for only pharmacological cardioversion. And the dosing is around 1 mg IV for greater than 60 kg and 0.01 mg per kg for weight less than 60 kg. Over 10 minutes we have to give, and it is repeated once in every 10 minutes. And ECG monitoring, like before, has to be done to look for the QTc prolongation. And the one thing we have to be aware of is that before starting these pro-arrhythmic agents which can cause QTc prolongation, we will have to make sure hypokalemia and hypomagnesium is corrected, and then only we start these agents. Adverse effects are similar: hypertension, bradycardia, syncope, sinus arrest, torsades de pointes, congestive heart failure, and vernaculant is very less commonly used. Class 4 antiarrhythmic agents, which are the calcium channel blockers, they inhibit mainly the L-type calcium channels, which results in slowing of anodal conduction and an increase in the refractory period of nodal tissues, and this decreases the automaticity and prolongs the PR interval. So it decreases mainly the automaticity and prolongs the PR interval. They primarily affect the action potential plateau and modulate the strength of muscle contraction in myocardia. So the phase 0, 1, 2. The phase 2 is what is affected, the plateau phase. And CCBs are mainly divided into two types, dihydropyridines and non-dihydropyridines. Non-dihydropyridines have greater cardiac selectivity and are used for mainly as an anti-arrhythmic agent for paroxysmal SVT and rate control in AF, whereas dihydropyridines are mainly used for treating hypertension. So coming to diltiazem or verapamil, which are the non-dihydropyridine agents. Verapamil is more potent than diltiazem and it results in greater AV nodal depression. So verapamil is more potent, and indications wise, paroxysmal SVT is used for as in paroxysmal SVT as we discussed earlier, and also for rate control in AF. And verapamil is more commonly used to abort SVT with a conversion rate to sinus rhythm similar to adenosine. And whereas diltiazem is more commonly used for the ventricular rate control in AF. And the contraindications include if it's a wide complex tachyarrhythmias, especially due to WPWH syndrome, we'll have to avoid these agents as it will activate that accessory pathway and increase the or accelerate the ventricular rate. So if we are suspecting a WPWH syndrome, we'll have to avoid these agents. And other contraindications include if there is a sixth sinus syndrome or AV nodal blocks, can cause further worsening of the heart rate, and also it should not be used in hypertension and also cardiogenic shock or administered with a beta blocker. So if the patient we had given a beta blocker, we should try to avoid these agents, and it also should not be given in VT, which is the wide complex tachyarrhythmia. In diltiazem dosing, we have IV bolus of 0.25 mg per kg over 2 minutes. We can repeat 0.35 mg per kg over 2 minutes, and if there is no initial response, and we can start on a continuous infusion with 5 to 10 mg per hour if bolus is effective, and the infusion may be increased in increments of 5 mg per hour until rate control is achieved. Maximum dose is 15 mg per hour up to 24 hours. Once rate control is achieved, we will have to change the oral dosing, which is given by this formula. And further, the immediate release tablets should be changed to extended release tablets once the patient is stabilized. Coming to verapamil dosing, we have 5 to 10 mg IV over 2 minutes, and if no response, we can give a second dose of 10 mg after 15 to 30 minutes, and if the patient responds, we can start with continuous infusion. The adverse effects, diltiazem is well tolerated and has a favorable safety profile, whereas the adverse effects of both are mainly bradyarrhythmias, asystole, fatigue, hypertension, headache, AV blocks, and the syncope, dizziness. Diltiazem's mainly oral route absorption is around 98%, whereas the oral bioavailability is around 40%, as it undergoes extensive first pass metabolism. And the distribution is around 3 to 13 liters per kg, and plasma protein binding of 70 to 80%, and hepatic, both are having hepatic metabolism via CYP 450, and excretion both are via urine and feces, same here. And the onset of action for verapamil is diltiazem is around 3 minutes for IV dosing. Oral dosing, it is around 30 to 60 minutes, and it peaks at around, for oral dosing, 2 to 4 hours, and for IV bolus, the duration of action is around 1 to 3 hours, and the continuous infusion, if it's discontinued, it can last for around 0.5 to 10 hours. And verapamil, it is mainly the similar absorption, oral greater than 90%, and the distribution is around 3.89 liters per kg, and plasma protein binding of around 90%. Similar metabolism, similar excretion, and the onset of action is also similar. IV is around 3 to 5 minutes, and oral it takes around 1 to 2 hours, and duration of action is around 0.5 to 6 hours, whereas oral dosing is around 6 to 8 hours. Then coming to other antiarrhythmic medications which are not included in these classes, atropine, as we all know, it blocks the acetylcholine action at the parasympathetic sites in smooth muscle, and this increases the cardiac output. It is ineffective in heart transplant patients because they lack the vagal innervation, and is not effective in second or third degree heart blocks or the infraescence block. And pharmacokinetics, the IV action is immediate action, whereas IM it takes around 15 to 30 minutes. It is metabolized by liver, half-life around 2.1 to 3.9 hours. Indications, it is mainly used for symptomatic sinus bradycardia only. If there is any associated hypotension or any reduced perfusion or any chest pain or any heart failure features, and if the patient is having only symptomatic sinus bradycardia, we use atropine, and the dose is around 1 mg every 3 to 5 minutes IV dosing. With max dose we can give around 3 mg. If ET tube we are giving it through ET tube, we have to give double the dose ideally every 3 to 5 minutes. And adverse effects are, it can cause tachyarrhythmias, constipation, serostemia, drying of the mouth, blurring of vision, photophobia, everything can occur with these agents. And other less commonly used agent is isoproterenol. It stimulates the beta 1, beta 2 receptors and increases the chronotropic, inotropic activities, and also causes the vasodilatation, the beta 1 and beta 2 actions it causes. And it's immediate onset of action, half-life around 2.5 to 5 minutes, duration around 10 to 15 minutes, and it's used for refractory bradyarrhythmias, AV nodal blocks, and refractory torsades de pointes. So it's rarely used in ER, and it's rarely used in ER. And it's contraindicated in patients with angina or pre-existing any arrhythmias, ventricular arrhythmias, tachyarrhythmias, and also in digoxin toxicity, which is contraindicated. And we have the dosing in bradycardia AV block, which is continuous IV infusion as 1 to 20 microgram per minute, and similar side effects are there with isoproterenol as well, hypotension, PVCs, tachyarrhythmias, ventricular arrhythmias, and all. And further coming to adenosine. Adenosine is one of the most important drugs we use in ER, and its action is basically, adenosine is an endogenous nucleoside. It slows the conduction through the AV node, interrupts all the re-entry pathways through the AV node, and restores normal sinus rhythm for patients in SVT. So it's mainly used in SVT with or without the re-entry pathways, and its half-life is around less than 10 seconds, very short half-life, because the metabolism is mainly systemic metabolism. All these cells can metabolize adenosine very fast, and the onset is very rapid and duration is very brief. So we should, while giving the dose, adenosine dose, we'll have to be very careful to deliver it with NS flush as well, and by raising the arm in which we are giving adenosine. So indications, as we said, in paroxysmal SVT with or without re-entry pathways. After failure of the initial vagal manus, we'll try. After that, if fails, we'll go for adenosine. It is not do not use with a known axillary pathway with retrograde conduction. If there is a retrograde conduction, then it can lead to ventricular arrhythmias. So it can be used as a diagnostic aid to differentiate VT or SVT with aberrancy, because SVT with aberrancy will also present as a wide complex tachyarrhythmia because of the aberrancy, which is due to either a left bundle branch block or a right bundle branch block. And with SVT, it will cause prolonged the QRS more than 120, and this will cause a confusion between whether it is a VT or a SVT with aberrancy. So in those cases, if we give amiodarone and if we give adenosine, and the patient responds to that adenosine, then it can be an SVT with aberrancy, not a VT. Okay, and the dosing is initially we give 6 mg over 1 to 2 seconds, rapid dose, rapid injection we give with the NS flush, and after that we will raise the arm in which we give the adenosine dose, and second dose we can give is 12 mg using the same procedures if the arrhythmia is not settled, and we can repeat 12 to 18 mgs, and if the SVT terminates and then again recurs, we will have to give the last effective dose, and such doses, 3 doses can be given maximum. And for central line administration, we should only give half dose, that is 3 mg initially, then followed by 6 mg, 9 mg, and for heart transplant patients, even lower dose should be given, 1 mg, followed by then we can repeat as 3 mg. Adverse effects are like very brief. We all know that duration of action is very less, so the adverse effects are also very brief even if it occurs. A patient will have a chest discomfort or pressure, headache, flushing, and nausea. These side effects are common, and they are very short lasting, and it rarely can cause bronchospasm and AF, and other adverse effects are very less common. And digoxin is mainly a cardiac glycoside, and it has mainly positive inotropic, negative chronotropic, and negative dromotropic effects. So it's mainly that positive inotropic effect which increases the myocardial contraction. It mainly acts via the inhibition of the sodium potassium ATPase and also the direct suppression of the AV node. That's why that negative dromotropic and negative chronotropic effects occur, and this leads to increased refractory period and decreased conduction velocity. Its pharmacokinetics in normal renal function, it will have around distribution of 6 to 7 liters per kg, plasma protein binding around approximately 25%, and metabolism is mainly via GI tract hepatic metabolism, and it's excreted via urine. Half-life depends on the age, renal and cardiac functions as well, and the parent drug around it takes around 38 hours, whereas its metabolites is lesser time, and onset is around orally it is around 1 to 2 hours, whereas IV it takes around 5 to 60 minutes, and the peaking action for oral dosing is 2 to 8 hours, whereas IV it is 1 to 6 hours, and its last duration is around 3 to 4 days. And in patients with congestive heart failure, hypokalemia, renal failure and thyroid disease, it affects the pharmacokinetics of digoxin, and it also has a narrow therapeutic index. So the therapeutic range is around 0.5 to 2 nanogram per ml, and its toxicity levels are more than, if it crosses more than 2, it can cause toxicity, and it has numerous side drug interactions that can be clinically significant, and its indications are mainly it's used for rate control in AF, not first line agent, and it's also used for symptom reduction in CHF, which is not relieved by diuretics or ACE inhibitors. It is contraindicated in ventricular arrhythmias and also avoided in patients with WPW syndrome. It has increased risk of ventricular fibrillation and in acute MI as well, and untreated beriberi disease, electrolyte imbalances, sinus node disease, AV blocks and renal impairment. So in such patients we should actually avoid the digoxin agent. And further, its dosing is for AF, it's usually used as 0.25 to 0.5 mg IV with repeat dosing of around 0.25 mg every 6 hours up to a maximum dose of 1.5 mg over 24 hours. And followed by, we can start with an oral maintenance regimen, which is 0.0625 to 0.25 mg OD. Digoxin level should also be monitored in such cases. And the adverse effects include GI side effects, which include nausea, vomiting and diarrhea. And other rare side effects include gynecomastia, skin rash, eosinophilia, thrombocytopenia and all. Those are rare side effects, and it can also cause cardiac arrhythmias such as sinus bradycardia, AV or SNOidal blocks and ventricular arrhythmias as well. So digoxin toxicity you should suspect when the patient presents with mental status changes, delirium, visual disturbances, hyperkalemia, seizures and all. We'll have to suspect digoxin toxicity, and even many types of arrhythmias can occur as a result of digoxin toxicity. Magnesium sulfate, it inhibits mainly the calcium currents. So magnesium sulfate mainly inhibits calcium currents, which causes early after depolarizations, and it causes that cardiac dysynchrony. So these agents actually slows the SA node activity and prolongs the myocardial conduction time. It stabilizes the excitable membranes and also is a cofactor in ion movement, and it has rapid decrease in it has a rapid onset of action, and it's mainly used for the Torsades de Pointes polymorphic VTs with a prolonged QT interval, which is the Torsades de Pointes, and it's also used for in cardiac arrest secondary to the Torsades de Pointes. And coming to the dosage, it is used as 1 to 2 mg IV as diluted in NS or 5% dextrose in water, and administered as a rapid bolus. Its adverse effects include vasodilation, flushing and hypotension as well. Thank you, and this is all about the antiarrhythmic agents. We discussed about the Vaughan-Williams classification of antiarrhythmic agents. We discussed in detail about each and every drugs in these classes, and we have also discussed each drug's indications, the pharmacokinetics, the dosing, the adverse effects as well. I hope you have all understood regarding this presentation. Thank you.